Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Christopher Giza with us today. Dr. Giza leads the UCLA Steve Tisch BrainSPORT program at UCLA. He is the vice chair for the he has served as the vice chair for the California State Athletic Commission, traveled to Afghanistan in 2011 as a civilian advisor to the Department of Defense, or DoD, and co-chaired the American Academy of Neurology's committee, which developed an evidence-based Practice Guideline for Management of Sports Concussions in 2013. Dr. Giza serves as the Center for Disease Control's Pediatric MTBI or Concussion Committee, the NCAA Concussion Task Force, and the Major League Soccer Concussion Program Committee. He is currently a professor of pediatric neurology and neurosurgery at the David Geffen School of Medicine and UCLA Mattel Children's Hospital. His research interests include neuroplasticity, recovery from injury, sports-related concussions, post-traumatic epilepsy, and brain development. Chris, welcome to the Concussion Corner podcast.
Hey, happy to be here, Jess.
I'm thrilled to have you. How's the weather out in LA today?
Pretty balmy. It's actually in the 80s, I think.
Oh my gosh. Yeah, it's spring, but I don't think Mother Nature has gotten the message out here east yet.
Well, you got to come out and visit sometime again.
I will. I hope to be out sooner than later is the plan. So I know that you've been traveling. Our listeners are going to get to know you in a little bit. But where have your travels taken you recently, and where are some good conferences that you've been to around the country and world lately?
Well, my most recent trip was a 2-week camping trip to Big Bend National Park in Texas and the Grand Canyon in Arizona. But on that trip, I, of course, had to put a little bit of work in, so I gave grand rounds for psychiatry at University of Texas Southwestern in Dallas. Earlier this month, I was also in Texas at the North American Brain Injury Society meeting in Houston, which was a really nice meeting. I haven't done a lot of international travel so far yet this year, but hopefully later in the year I'll be going to Northern Ireland and maybe even the Ukraine.
Oh, that's wonderful. Yeah, we've had some pretty amazing listeners from around the world so far, from Thailand to Ireland and Australia and everywhere in between. So it's been a neat kind of way to track and trend our listeners. And so if you do see Dr. Giza in your country or native land, definitely go see him. So, Chris, essentially I start off every podcast with very Simon Sinek-esque, with starting with why. So essentially how and why you got involved not only into neurology, but specifically into the concussion world. And I'd love to let the listeners in and share that information if that's okay with you.
Absolutely. I think, when I was in college, neuroscience as a department didn't really exist. I was a biochemistry major, but I was interested I said, well, the two things that would be sort of the final frontier would either be astrophysics or neuroscience. And I wasn't smart enough to be an astrophysicist, so I decided to go into neuroscience through a kind of a biochemistry perspective. Once I was interested in clinical neuroscience, then you had to kind of decide between neurosurgery, neurology, pediatric neurology, and psychiatry. And I think it just kind of came naturally, although it took me a while to find, with training in adult neurology and then eventually finally settling in on pediatric neurology as my area of clinical expertise. Within all that, I didn't really know whether I would subspecialize. At UCLA, our training program focuses a lot on epilepsy and epilepsy surgery and things like that. And so I enjoyed taking care of those patients, but I also wanted to do something different. And so I took some time off after my clinical training and went to Yosemite National Park and worked on the search and rescue team essentially as a rescuer, probably the worst climber, but the most medically trained member of that team. And one of the things that came up in that time was I saw a lot of people with traumatic injuries. Now, they weren't all head injuries for sure. There were some head injuries, some spine injuries. Most were orthopedic injuries. But that kind of got me thinking about head injuries in general. And when I first started looking into kind of the epidemiology of head injury and seeing, that it was sort of the most common cause of acquired death and disability under the age of 40, and I was just wondering, how could I have gone through all this clinical neuroscience training and heard almost nothing about this? It was, as we used to call it, the silent epidemic. Mm-hmm. And so that's kind of what drew me to traumatic brain injury in general. I actually didn't start out really focusing on concussions at all, and I think there was even a time when I said I'm not going to be the concussion person. Was focused on more moderate to severe TBI. We've done a number of research studies in the ICU, working with neurocritical care groups and things like that. But around 2006, 2007, mild TBI patients, concussion patients, sports patients just started coming to my brain injury clinic, which was set up for more severe kids. And, one thing after another, pretty soon most of the patients that were coming were concussion patients. And so then that sort of just expanded the type of injuries that I was taking care of. And then we find ourselves here today.
Mm-hmm. Indeed, and I think that's such a similar story to many of the folks that have been on this podcast, Chris, is, we were kind of there at the right time. 2002 to 2008, we had the conversations of MTBI concussion, but 2008 kind of really got blown up with some of the NFL conversations and media and the New York Times starting to pick up the word concussion and report on it, and we all just seemed to be practicing, and it kind of literally fell into some folks' lap, like yourself and mine.
Yeah.
What I found interesting is I actually don't think I realized that you were a part of the Yosemite search and rescue team. Is that where part of your love, kind of fell in with, nature, or did you have that love beforehand?
I certainly had a love of nature beforehand. I grew up in a rural area in West Virginia, so I was used to being outdoors and doing outdoor activities. And then after moving to California, with so many outdoor opportunities and the great weather, my wife and I traveled all over, and one of the places that we liked the most, that we really fell in love with, and I guess in some ways that's also where we fell in love, was Yosemite, because we got married in Yosemite in 1996.
Oh, very cool. Yeah, I'm from New York City, so I'm from the other side of the country, the East Coast, West Coast connection here. And I really did. I'm a young, educator and traveling around the country myself teaching. And I really did. It was a very positive. It was a shame on me moment, because I really didn't realize how much less access in some of, I joke about the square states in the middle, but these beautiful, states like New Mexico and Arizona and Montana and Utah and all these Colorado, these ski and extreme sports states, from BMX and things like that, and how much head injury is either not reported or underreported, because, again, it's not a quote-unquote athletic training documented injury, very much like the basketball or wrestling, those indoor sports. So I've really done quite a bit over the last couple of years just learning about outdoor, adventure sports and things like that. It's really been quite amazing from a head injury standpoint.
And the outdoor sports, and the non-team sports also bring up different issues. So a lot of times with sort of team sports or some competitive sports in school, you think about risks of concussion, mild head injury, catastrophic injuries are very rare. Whereas in a lot of the extreme sports or the gravity sports, snowboarding, skiing, road cycling, climbing, all those things, in addition to risk for concussion, actually the big problem is the risk of a more severe head injury, like a skull fracture or a subdural hematoma and things like that. And so the background, coming in from a background of traumatic brain injury that was originally focused on more severe things, I felt that I was kind of uniquely qualified in that area. And then, of course, we realized some of these hikers, some of these climbers, some of these skiers are also getting concussive injuries, and that may also have implications for their short and long-term performance.
Indeed, and I spoke with Jeff Kutcher about this on our first two episodes of the podcast. But we know that, the word concussion is very new for all of medicine, and we know that 2015 was that first formal didactic year that neurologists did have training in concussion from a formal didactic residency training standpoint. In your career, where have you kind of seen the trends shift and move forward to, kind of as we all have in medicine, with the care of concussion and the evaluation of it as well?
Well, I think before concussion became kind of the big thing that it is now, a lot of concussions were taken care of by primary care providers, by sports medicine providers, orthopedic doctors, in emergency room settings, and neuroscience trained clinicians like neurosurgeons and neurologists and psychiatrists didn't see that many concussion patients. The neurosurgeons would see the more severe injuries, neurologists if you had a seizure or something like that, but a lot of individuals with concussive injuries kind of fell through the cracks. They might have gotten some initial assessment and then no follow-up, or maybe they didn't even present to medical attention at all. They just kind of toughed it out on their own and then sort of worked their way back into whatever they were doing. So it was a much different perspective back then. And of course, if you weren't rendered unconscious by your injury, a lot of times people didn't even worry about whether an injury had occurred.
Indeed. And we know that, usually greater than 90% of concussions, or MTBI, those two words are synonymous for our audience members, present day at least, that most folks don't. About 90% don't lose consciousness. So again, we really didn't know what we were looking at, so we knew what we were looking for in terms of a healthcare standpoint. So we've really come full circle to the, in 2018, calling this injury a rehabilitative injury. This is something that can be cared for and should be potentially managed by, a skilled and trained healthcare provider in concussion. But we know that is few and far between, and folks are having difficulty with access, finding quality care. So paying attention to folks like Dr. Giza here on the podcast, if you're out west and things like that, and starting to make those connections are really a wonderful thing.
Fantastic.
So, Chris, in terms of the role of neurology in concussion, what is the role of a neurologist, both adult and pediatric, and why neurology for concussion?
Well, I think neurologists have a unique role in traumatic brain injury as a whole, because neurologists are one of the specialties that can take care of patients in the ICU, can take care of patients in the emergency department, in the inpatient setting, but then also can translate into the outpatient clinic and other things like that. And so it always surprised me that traditionally neurologists weren't really that involved with traumatic brain injury, or sometimes only in the sort of severe coma setting in the hospital. And the milder, quote unquote, milder TBI or patients with concussions were typically not seen by neurologists. But I think if you look at what are the potential sequelae that people with concussions can suffer, and particularly those who develop persistent symptoms, those symptoms all fall into things that neurologists receive training in terms of headaches, neuralgias, nerve impingements, visual disturbances, cognitive problems, attentional problems, even all the way to the far end of the spectrum. If you think of individuals who have had multiple repetitive injuries in the setting of boxing or other sports, who may have cognitive decline or dementia. These are all things that outside of the context of traumatic brain injury, neurologists take care of. We take care of headaches, we take care of migraines, we take care of patients with dementia. But for whatever reason, if it occurred in the setting of trauma, less interest, or there's less consideration of those patients, which I think is unfortunate. And it's important to recognize now that neurologists are becoming interested in these things, that other doctors, other clinical providers were there when neurologists weren't. And we need to recognize their contributions to the field. People from sports medicine, people from emergency medicine, other specialties, physical medicine and rehab, have been taking care of some of these patients. I think what neurologists can add is, we can add our clinical neuroscience expertise, is that we understand more about doing neurological examinations to look for subtle findings and how to interpret them appropriately. I think it can be very helpful in the early settings after a head injury, if you're trying to evaluate this is a concussion or is this something more severe, like an intracranial bleed, a neurologist has some advantages there. And then in terms of the longer-term management of some of the chronic sequelae, like headaches and cognitive problems and attentional problems, even post-traumatic seizures, although those are very rare in concussions, but in traumatic brain injury, post-traumatic seizures are a problem. And again, those are areas that most neurologists have some comfort in taking care of and in properly evaluating.
Indeed. In your clinical career, have you been seeing any like medication sensitivities or anything like that with any of your patients, whether they be acute, subacute, or chronic, like medication sensitivities or insensitivities and things like that?
Maybe explain that a little. What do you mean when you say?
So in terms of, from an endocrine standpoint, we've been keeping track of folks from an endocrine, like hormonal standpoint. And we do involve folks from, endocrine and things like that, just to kind of screen for folks with a little more persistent symptoms. Some common themes that I've heard from a lot of patients, including myself, are some just medication insensitivities, like just from a metabolic cascade. Let me take that back. From a metabolic standpoint of just being insensitive. So, for example, a patient a couple weeks ago said, like, hey, Jess, you know what? I took a Benadryl and I was just totally knocked out. And this is like a 225-pound male that was a former football player. And he was like, he just took an over-the-counter Benadryl and he just completely felt off. And this is a man with repetitive head injuries and concussions, throughout his career and life. Do you see any of that with any of your maybe more persistent folks or even the subacute phase folks reporting any of that to you?
Well, I mean, you certainly encounter a number of individuals who are very sensitive to medicines in any sort of neurology kind of setting. But I think, the challenge there comes is that, some people are very sensitive, and then on the other hand, some people are very insensitive. Headaches can become very intractable to medications that have very good, randomized controlled trial data that shows, oh, this medication is effective for these kind of headaches. And then there are always some individuals who don't respond as well. And I think, the challenges there usually depend on making sure you're using the right medicine and the right dose for the condition. And if you find somebody who has very bad headaches that aren't responding to the medication management, the most common things I see are either the dose hasn't been titrated appropriately, or perhaps that's not the optimal medication for their type of post-concussive headache. It's not like there's a single medication that works for everybody. I think, this is a little bit tangential, but I feel like one of the things people do commonly is we sort of lump everything into the basket of traumatic brain injury. And we think it's a single diagnosis, and we think that there's a single or that there's a prescribed set of treatments that sort of work in general, and that turns out not to be the case. Traumatic brain injury is like saying, oh, you have an infection. Well, there's 10 different types of infections, or 100 different types, and depending upon what kind of infection you have, there's different treatments. The same thing if you say you have cancer, right? Some cancers are very dangerous, some are less serious, and they have different treatments. Head injury has that same kind of spectrum too, that there are head injuries that can be fully recovered within a period of days with minimal intervention, to head injuries that are so severe they require brain surgery and ICU hospitalization and other things. So there are actually many different treatments to be effective for head injury and for the sequelae of head injury.
Indeed. And, I'm happy to go down that rabbit hole with you. And I think it's totally appropriate for folks to listen in on this conversation. Brian Hainline, repetitively, wherever he goes, Dr. Hainline is the chief medical officer of the NCAA. And, he's a walking, talking breath of this information. And he literally opens up most of his conferences with, there are over 43 working definitions of concussion. And only one of them is evidence-based. And that's such an important, concept that you brought up here, Chris, because we still don't really have a working definition that we agree upon internationally for concussion or even traumatic brain injury for that matter. And, with cancer, I really believe, and this is one of my talking points when I travel around, is that with cancer, we diagnose like non-Hodgkin's large cell lymphoma. We're getting down to the nitty-gritty with cancer diagnosis, and that's why research, quite frankly, has gone so far with cancer. And brain injury is still so underfunded, and under and in the past poorly researched because we just weren't agreeing on the definitions. So we definitely need to take that there in terms of getting much more specific. I know you just published something on a network approach to examining injury severity in pediatric TBI with Dennis et al. And that crew in 2017, and talking about, concussion is a network, like a brain network injury. And that's why we can't just, quote unquote, it's not like a fracture where you can't just image the brain and find the bleed or find the fracture because there isn't one. So that's definitely,
and it's an important point because the Dennis paper is actually kids who've had moderate to severe TBI, but it's an example of how when you publish something in moderate to severe TBI, it gets lumped in with concussion and mild TBI, even though those might be different injuries. But you're right that the idea of a network damage is one of the pervasive underlying parts of the pathophysiology for all biomechanical traumatic brain injury. But there is a distinction between the mild TBI and the concussion, the moderate TBI, patients with tomas, patients with infusions. Each of these different types of traumatic brain injury then has to have the appropriate treatment for that type of injury. Absolutely.
Are you in the camp here, Chris, with like potentially changing definition of concussion, or are you for keeping concussion and MTBI, those words, synonymous? Are you in for any evolution of those definitions?
Well, I would say, just to be antagonistic, that I don't think concussion and mild TBI are synonymous.
I'm in that camp as well, but but for present day purposes, for definitions, we're looking at it, and I in jest laugh at the Glasgow Coma Scale with basically 0 to 29 being an MTBI and any 30 minutes and on being a moderate. Those are someone being unconscious for 28 minutes is considered still mild. So I still think we need to, even for our moderate and severe TBIs, I think we need a little shift in definition as well there. But that's my own opinion and soapbox.
Right. That's the physical medicine and rehab definitions. So, but Glasgow Coma Score would say a score of 13 to 15 is considered mild TBI. Right. But it's really designed to sort of, and so that's where I think the definition of mild TBI came up was, a Glasgow Coma Score of 3 to 8 was severe. Those are patients usually comatose. 9 through 12 on the GCS would have been a moderate. Those are patients who might have been disoriented, but were sort of kind of moving around and maybe partially following commands. And then patients with very little deficits on the GCS, 13 to 15, those patients were considered mild across that whole spectrum. But when you talk about concussion, but you could have a mild TBI and still have a small brain bleed. I've seen plenty of patients who had a small subarachnoid or a small epidural or linear skull fracture, and then the Glasgow Coma Scale that was perfect. To be classified as mild, even though they had something probably more than what we would say is a concussion, which shouldn't have a bleed, which shouldn't have a fracture. So definitions are a big deal from the point of defining the proper type of traumatic brain injury. But then I was wondering, you mentioned you talked with Dr. Kutcher earlier. Did you guys talk at all about the probabilistic diagnosis of concussion? Like definite, probable, possible? Your
2014 article, I don't know if we did. I'm trying to think. Carolyn Baxter may have. We may have in his second episode, but we can definitely go into that as well because I think that's a really important concept for folks to kind of grasp onto.
Yeah, I think so there's a few things you have to make clear because we're talking out into the general world. I think the first thing is that if you're taking care of somebody who's participating in an athletic event or in a recreational activity and they have a blow to the head and they have any signs or symptoms, headache, nausea, vomiting, confusion, disorientation, any of the typical symptoms for concussion, in that setting, your decision is just a yes or no decision. Do they get to continue or not? And if you suspect a concussion, they should sit out. So that's, we say, when in doubt, sit it out. And that's a yes-no decision on the sideline that doesn't necessarily require a definitive diagnosis. If you suspect it, then they should sit out. In the setting of an experienced clinician or a researcher, if we just say, yes, this is a concussion, or no, this is not a concussion, then that becomes a little more problematic because there's no clinical setting that I know of where someone can say, I'm 100% sure this was this. I'm not 100% sure this was a concussion. Oh, I'm 50% sure this was a concussion. In the real world, things are shades of gray. And so one of the things that Dr. Kutcher and I have proposed, and is also kind of loosely covered in the concussion and sport group's definition for what a sport concussion is that there has to be a certain number of components, and the more components you have, the more likely you call this of injury. So if there is a viable mechanism of injury, there has to be a remembered or reported impact to the head or impact to the body that accelerates the head or something, the head striking something. There has to be a mechanism. If you put your head on a pillow and get a headache, that's not a viable mechanism. That's a different problem. But if your head hits the turf or your head hits an elbow when you're jockeying for position on the basketball court or you get hit with a hockey stick, that's a mechanism. So you have to have a mechanism. The second thing you would want to have to be sure is you'd want to have kind of a temporal onset of symptoms. So you want the symptoms to happen somehow related to the impact, Maybe not instantaneously. We know that people present with delayed symptoms, but not like 10 days later you start having symptoms. That would not be typical for a concussion. The pathophysiology that we've all learned and talked about occurs within minutes after injury, and so symptoms referable to a concussion, we would say should probably at least have their onset or be noticed within a day or two. They should be typical symptoms, right? If you're having hallucinations or other things, those aren't typical for concussion. If you're having headache, nausea, vomiting, those are. So you want to have a mechanism. You want to have the timely onset of symptoms. You want to have the symptoms be, typical symptoms for concussion. And then an important other consideration is, are there other conditions that could be contributing to the acute symptoms? We saw a young man, football player, who came off the field after practice. Obviously was playing football, so there was contact, but there was no particular big hit. Nothing unusual seemed to have happened. But he came off. He had terrible headache, nausea, vomiting, was a little bit confused. And of course, the decision there on the sideline is no go. You got to come out. This could be a problem. But we're not making a diagnosis yet. So the player's out. Turns out body temperature was 106. Hyperthermic, not really sweating, cooled him off, hydrated, mental status cleared, headache cleared, nausea and vomiting got better. So in that case, the acute symptoms, while they looked like a concussion, ended up not meeting the criteria. There was not a good mechanism. There was now an alternative explanation that the patient was hyperthermic. And so to take him out and treat him like a concussion and not make the diagnosis of hyperthermia and dehydration would have been bad management in that case. So I think you want to have mechanism, you want to have temporal onset of symptoms, typical symptoms, and you want to make sure that there's not another alternative explanation for those acute symptoms.
Indeed, and that's why it's so important for our listeners to connect to. It's so important to do these comprehensive and targeted physical examinations on these folks, and we're not just going by symptoms, because we know that folks with depressive symptoms, folks that are hypothermic or dehydrated, again, even me at the end of the day, I present with a little agitation. I'm just ready to go home and get some exercise in on the bike. But that's why we don't go with a symptom-based diagnosis, especially with if it's athletes or folks working on a line or things like that with their livelihood in tow, because then that technically, if they're in a league of some sort, it will put them into this whole 7-day trajectory of a return to play, guideline, for graduated return to play, return to activity and things like that. So very important to connect to what Dr. Giza was just talking about there, of really paying attention to the mechanism, temporal presentation, and making sure you're doing these comprehensive targeted physical examinations on these folks.
No, those are all good points. Yep, I agree.
Awesome. So, we're coming up to the 30-minute mark here, and I make sure for our listeners that, if they're on their way to work or in the gym, we try and keep their attention for that 20 to 30-minute sweet spot. So I think what we'll do when we come back is that we'll talk a little bit about the AIN, the American Academy of Neurology, a little bit about the Department of Defense, and I really want to hone in with you here on really the importance of having a pediatric neurologist and a pediatric trained clinician and physician working with, pediatric concussion. Does that sound like a good plan for you?
Sounds excellent. I'm very happy to do that.
Awesome. All right, guys. So for part 2, which will come out with Dr. Giza, right now, what's the best way for folks to reach out for you for this episode? And, are you on Twitter? What's the best way for folks to say howdy?
Yeah, probably the easiest way is my Twitter handle is very short. It's @Griz1, GRIZ1, and it has my name on it too. So that's probably one of the easiest ways for people to reach me.
Excellent. And if you'd like to find Dr. Giza for any professional work or referrals, you can find him at uclahealth.org/brainsport. That's uclahealth.org/brainsport. Okay. Well, Chris, thanks so much for coming on to Concussion Corner.
Fantastic. Happy to be here.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.